to be here out of Faculty of Health. Well, actually, I'm from the Faculty of Medicine, so it's a very different conference for me to come to. I bring a different perspective as an epidemiologist, and I wanted to sort of describe how I ended up here first, and as well as introduce some of the concepts that we'll be talking about in the panel today. So I was funded by the Australian Heart Foundation to look at social isolation as a risk factor for cardiovascular disease. Social isolation is around the number of contacts that you may have in a period of time, like a week or a month. It's not just family and friends, but it's about the community that you live in and what resources are available for you to connect to. Social support is seen to be really connected to social isolation, and that's around how people utilise the contacts that they have. Whereas loneliness is often discussed in the media, and this is a discrepancy between what people have and what people want in terms of social contact and social connection. So I decided to look at all three at the same time, not just social isolation, that sort of seems silly. And what I've found is that people with poor social health, so this is like an umbrella term, tend to have a greater severity of chronic disease risk factors. So this could be a lifestyle, such as undertaking less physical activity, as well as biomedical factors, such as having higher blood pressure. People with poor social health have a lower quality of life, have an increased risk of cardiovascular disease and dementia, as well as use healthcare services more frequently, have a lower outpatient rehabilitation attendance, as well as worse outcomes after they suffer health events, so rehospitalisation, for example. And I want to just give one example of what I'm talking about here. I've used a data set with over 10,000 healthy Australians aged 70 years or more. This means that they have no real reason to die within the next 5 years. They've never had a cardiovascular disease event, they have no cognitive decline. Essentially, the person that I want to be at 70 is who I was talking to. And what we found was that people with poor social health, even though that they were healthy, when they had poor social health, they had an increased risk of cardiovascular disease in the next 5 years. So if they were socially isolated, they had a 66% increased risk. If they had low social support, it was double the risk. And if they were lonely, they had a 255% increased risk of dying from cardiovascular disease. And I really want to emphasise what I was looking at when I talk about some of these metrics. I'm talking about not just infrequent, short-term or short bouts of isolation or loneliness. I'm talking about something that happens for a long time, severe loneliness. So it's part of the human condition to feel lonely sometimes. It's actually considered an indicator, like thirst or hunger, that you should make some changes in your life. And if you feel lonely, say a day of work, even if it's regular, it's not all that concerning for your health. But if it's 3 or more days per week, or some people use 4 or more days as the cutoff, then we know that it has negative influences on health and well-being. And you can say the same with social isolation or social connection. For instance, if you move suburbs or houses, downsizing, for instance, in later life, you may have a temporary less social connection, and then that should build in a new community, and we wouldn't expect that to have an impact on your health. So from my research, I have some recommendations. I did this in older Australians, but I feel that we could probably expand it to other cohorts. My recommendation is that people should participate in community events at least once per month. They should have contact with 4 or more relatives or close friends within a month, and that could be face-to-face, which would be great, but it could also be email, phone, video conferencing and text messaging. And then have an aim for 4 or more relatives or close friends with whom to discuss private matters with or call on the help. And if you have someone that fulfills both of those buckets, you can count them twice. So I think that there's also a really misunderstanding about how much social connection you need. This is actually, if you read this, I'm talking about really severe social isolation, lack of social connection or low social connection. And that's what I'm interested in changing. So I was thinking, but how do I do this? Like now I know what the recommendation is. How do people change or increase their social health? So I made this great list of Australian-wide social resources, which I try to promote wherever I can. But how about if you're not on social media or you're not connected to your community? How are you meant to find these resources? So imagine the next time you go to visit your doctor, counsellor, social worker, podiatrist maybe, and they write you a prescription for resources in your community to boost your health and well-being. This isn't your typical prescription, it's got nothing to do with medication, and it's got nothing to do with a referral to a clinical specialist, but it's a referral to music, pottery, time in nature, tickets to a dance performance, museum, maybe a botanical garden walk. These could be by yourself, it could be in a group. Wouldn't that be wonderful? Now, a lot of GPs actually want to help people with the holistic care. They see that their role is not just medical prescriptions, so they're wanting to have a model that allows them to socially prescribe. I'm going to go through each element of social prescription so you can understand what I'll just say is the optimal model. There are different models which I will discuss. So here we have someone who would like to enrich their life. They talk to a trusted referrer. It could be a GP, other health professional, podiatrist, as I mentioned. And they see, oh, this person could benefit from social prescribing, great. They then refer them to a link worker. Now, a link worker is a resource in itself. A link worker has the time to discuss through a holistic needs assessment, has knowledge of the social resources in the area, and they work with the individual to create a personalised plan, identifying opportunities and avenues to enrich and enhance their quality of life. The link worker then supports the person to attend the services, and it's not just what is available, but could be support about social anxiety or travel arrangements to get somewhere, particularly if someone has limitations with mobility. And the link worker continues to work with this person over a short time, say 3 months, to make sure that everything's going well, or maybe the plan needs adjustment, maybe they didn't like the prescription, maybe they need to look at another prescription. And in an optimal model, they record some information that then goes back to the trusted referrer. So in this case, it would be a healthcare professional. Now there is another model where the trusted person undertakes a holistic needs assessment themselves. But the problem with this is that it's probably not their job to have a really good understanding of the local resources available, and they're probably offering just a few ones that they've found out about coincidentally or that's been advertised to them. Also, they probably don't have time to follow up with these people in a holistic manner. So, if there's a healthcare professional, they're probably then having to address health concerns rather than social prescription and helping with social anxiety to get there, for instance. So who is social prescribing for? Everyone. Social prescribing addresses social determinants of health, which are any aspect of where we live, work or play that affect our health. Many circumstances can contribute to a greater need for social prescribing, including living with social isolation, depression, anxiety, ageing and other life stage transitions, lengthy recovery from injury, or living with cultural and language minority groups. There are currently tested models in Australia that focus on subgroups of the populations. For example, it could be a group based on an ill health concern or their age, so younger or older. But this is just for funding purposes. In the UK, the government has spent billions of pounds to incorporate social prescribing in the health system, and it's for everyone. There's numerous benefits of social prescribing. Canada's just published a report showing that there's a $4.20 saving for every $1 spent. There's numerous benefits. I'm not going to read through all of these. Numerous systematic reviews as well as individual studies showing improvements to socialising, well-being, health outcomes including blood pressure and physical activity, reduced healthcare services, and increased readiness to return to work. So how does arts or prescription feel, how does it link into social prescribing? Well, it's the specific aspects of prescribing arts, culture, and nature experiences. Now, nature experiences tends to be talked about as green prescription and blue prescriptions as well, so you may hear some of those terminologies today. But what's important is it's not just joining a community class book program. There's lots of people that already are attending, and that's fantastic. I strongly believe that's benefiting their well-being. But what we're trying to do is ensure people that don't know about it or are in a group of high risk for ill well-being have access to social prescribing. So there's a clear health pathway with referral. And it can go through the link worker or it can go straight from the health practitioner. So the health referral mechanism gives it some accountability, and the purpose of engaging in this activity is for health and well-being as opposed to leisure and education. So now we get to hear about some arts and prescription programs within hospital and health services, such as Claire's example, as well as referral from hospital health and GP community programs, which are Melissa, Christina's, and Helen's examples. So I'll let you introduce them. Thank you.
Thank you. Just stay for a minute in case we have questions. So thank you for your We've got time for one or maybe two questions on the broader sort of social prescribing idea, if anyone has one. Yeah, over here.
Does it matter if the link worker is a digital or does it have to be a person contact?
Yeah, it's a great question because I don't think that we've, so definitely we need digital prescriptions. There are a lot of people that would prefer that and also have mobility issues. So when we talk about social prescription, it can be to a range of different activities, some online, some not. With the link worker, I do believe the optimal model would be in person, but it doesn't mean that they can't offer digital appointments.
And in fact, just on that, we were doing one of our projects, and of course COVID hit in the middle of it, and so everything had to go either telephone or Zoom online. So it is possible to do the link work in that way, but I think everyone agreed that it was easier to do, you know, sort of appointments face to face or even home visits, depending on what service you were with. Maybe one more down front.
So Emma O'Brien from Royal Melbourne Hospital of Music Therapy and Stropfire. Is there any, in the future, capacity to look at some sort of accreditation for these people that we're prescribing to? Because often, you know, we have to dig really deep to go, someone says, I'd love to keep singing, and then I have to do all this extra work to make sure that who I'm sending to is sort of going to follow through. Is there any capacity, or is that, are we going to do that?
I think that's probably the topic we're just about to talk to.
Okay,
So
great.
hold on. All right, so we might just get straight in